box.
So
So
we
this,
usually give 30 seconds for the answers and then make it.
okay, ma'am. Okay. So I would like a complete diagnosis, not a partial diagnosis. And even for the first intervention, again, where exactly you want to do the first intervention, in the delivery room or in the NICU. And even for the antenatal markers, if you're writing liver, you have to be very specific. What do you mean by liver? So take your time, write proper sentences to complete your answers. Um, so yes, most of you have got it right. It's a CDH, but again, I mean, just saying CDH does not make it complete. So it's a left-sided congenital diaphragmatic hernia. We intubate in the delivery room. So usually that's what the recent guidelines and the protocols say. The Euro CDH guidelines as well as the Canadian guidelines have um, highlighted the importance of intubation in the delivery room if you are sure of this being CDH, usually from the antenatal scans. And the observed to the expected lung head ratio and the total lung volume are essential antenatal prognostic indicators. So you can get the observed to the expected lung head ratio from ultrasound scans and the total lung volume from MRI scans before delivery. So if there are associated syndromes along with the CDH, that's a bad prognosis. The right has got a worse prognosis compared to the left. Again, preterms again carry a worse prognosis. Yes, solid organs in the chest are associated with poorer outcomes. So just saying liver, again, the left lobe of liver becomes much more important over here. So again, you have to be very specific about what you are writing as answers. Okay, let's move on to the next question. So which one is the most common type, A, B, C, or D? And what other anomalies should we check for these patients? Okay, so yes, most of you have mentioned about Vactorel. Can you write Vactorel in detail, what exactly it means? Okay, so type A is most common. So that's esophageal atresia with a distal tracheoesophageal fistula, not type C. So, so the type A is around 91% and the rest are around 4 and 1%. Okay, coming to the next question. So interpret the blood gas. So yes, the lactate is elevated. There is metabolic acidosis. It is a pneumoperitoneum. Very difficult to say whether there's a bit of yeah, there is air under the diaphragm. So that's a pneumoperitoneum. The immediate steps of management is not surgical management. The baby has to be stabilized medically before we move on to a surgical management. So the immediate steps will be putting an IV, starting fluids, having the baby nil orally, starting on empirical antibiotics, and then definitely a surgical referral. But you medically stabilize before you move on to a surgical management. Okay. So question 4. Identify the skin lesion. Yeah, so most of you are right. So erythema toxicum and reassurance, no active management. Just wait and watch. Question 5. So it's benign sleep myoclonus. We again wait and watch. We observe reassurance. Okay. Question 6. So we are discussing congenital rubella over here. So CMV retinitis is not the right answer. So CMV is different from congenital rubella. So most of you have got the cardiac anomalies right. So PDA and PS. Ocular abnormalities, many of you have mentioned about cataract. The other one is glaucoma. And yes, it's a sensory neural hearing loss. So these are what we see in a congenital rubella. We also see skin lesions, we see organomegaly, we see thrombocytopenia. Okay. So what is the diagnosis over here? So what is the differential diagnosis? Yeah. So it's the congenital hyperplasia of the depressor anguli oris. Risk factors, yes. Difficult delivery, anything else as risk factors? Yes, instrumental deliveries. It's mainly for a large for gestational age baby. Yes, treatment is mostly physiotherapy. And we also need to give a eye patch or an eye pad, protect the eyes. Uh, in severe cases, nerve decompression can be tried, but it's mostly conservative to begin with. Okay. So there's a video over here. Observe the video carefully and let me know what you see. Okay, you can see a olive-shaped mass, which is very good. What does IHPS stand for? What is the full form of it? So it's not CHPS anymore, it's IHPS. So yes, you can do a USG to confirm. Right. What will you see in the USG? Anything specific that you ask for in the USG? Yeah. So good, you see the length and the thickness. And what is the definitive treatment? Okay, good. So yes, pyloromyotomy. Surgery, just writing surgery does not mean that's the treatment. So you have to be very specific what kind of thing that we are looking at. Okay, let's move on to the next question. So read through it carefully. Yeah, NATE is the possible diagnosis. What other investigations will you consider? Do you need to rule out anything for thrombocytopenia in this baby? Anything else which has not been done, as you can see in the question stem? Yeah, torch should also be done. What causes the possible diagnosis? Yes, some of you have answered, but you have just written HPA, so that's not going to give me the answer for this question. You have to be very specific. So who has the antigen, who has the antibody, and how it results? And how will you treat? And how will you also address? subsequent pregnancies. You're writing about IVIG, but I don't know, do you want to give IVIG to the baby or to the mother in a subsequent pregnancy, or what exactly you want to do? Okay, so there's not much role of, so IVIG can be given to the baby, but not as the first step to it. So it's actually the sensitization of HPA negative mother to a HPA positive father with a transplacental transfer of immunoglobulins. So what you need definitely is HPA-1A negative platelets. And then, yes, if the thrombocytopenia is persisting, you can always think about immunoglobulins. So for subsequent pregnancies, you need to do a genotyping of parents and see what exactly is happening. So few of the HPAs can be tested, but all the 30 HPAs are not tested. So there are tests which look into few of those, of which HPA-1A is the most common, that too in the European population. We don't have a robust Indian data. So in subsequent pregnancies, we have to see if the father is heterozygous or if the father is homozygous. If he is homozygous, the therapy should be started as early as the 13th week of pregnancy with weekly immunoglobulins. And prednisolone can or may not be given. So depending on the how severe the previous infant was. And if the father is heterozygous, the risk of the infant can be determined by molecular analysis of fetal cells. So, and can also be determined by a chorionic villus biopsy or a amniocentesis. Okay, so a brief chart looking into early thrombocytopenia and late thrombocytopenia and what we should consider as the differential diagnosis. Okay, let's come to the last question. So please be very specific with the answers. So yes, sepsis screening, calcium, electrolytes, anything else that we need to check? Something very important. I'm still waiting for that answer in the chat box. So yes, blood glucose. That again should be checked whenever we are dealing with neonatal seizures. What is the first line medication for this baby? Which anticonvulsant will you give? Okay. Phenobab it is. Happy to see that there are no other answers coming up. Levetiracetam is still not the first line anticonvulsant. Any other investigations to be considered apart from blood tests? Yeah, lumbar puncture, EEG, good. Anything else? USG, yes. Yeah. And what are the things we should check before discharge for the baby? So yes, neurology, anything specific in neurology that we should check? So feeding assessment and